Welcome to Pulse and Pressers, where critical care gets crystal clear. In today's session, we'll explore an ultra-short-acting dihydropyridine calcium channel blocker used for the precise, minute-to-minute management of hypertension in critically ill patients. We'll break down its pharmacology, receptor-level mechanisms, hemodynamic signature, and how to optimize its use in the high-stakes cardiac and post-open heart setting. Clevidipine is a third-generation dihydropyridine calcium channel blocker, a pure arterial vasodilator, designed for rapid titration in hypertensive emergencies and perioperative blood pressure control. Unlike oral agents such as amlodipine or nicardipine, clevidipine's lipid-based emulsion allows for instantaneous onset and offset, making it ideal for ICU and intraoperative use. Its primary indications include acute hypertension in cardiac surgery, aortic dissection, and neurocritical care, where tight hemodynamic control is essential. In critical care, clevidipine bridges the gap between pharmacologic precision and physiologic stability, allowing for surgical-level control without compromising perfusion. Clevidipine selectively inhibits L-type calcium channels on arterial smooth muscle cells. By blocking transmembrane calcium influx, it reduces intracellular calcium concentrations, leading to arteriolar dilation and decreased systemic vascular resistance. It does not affect venous capacitance vessels, preserving preload and maintaining cardiac output. At the cellular level, the decreased calcium availability reduces myosin light chain phosphorylation, producing rapid smooth muscle relaxation. Clinically, this results in an almost immediate fall in mean arterial pressure, with minimal reflex tachycardia due to its balanced arterial selectivity. Clevidipine's pharmacokinetic profile is engineered for precision. It has an onset of action within 2 to 4 minutes and a plasma elimination half-life of approximately 1 minute. Its context-sensitive half-time remains stable, even with prolonged infusion, meaning that when you stop the drip, the patient's blood pressure normalizes within minutes, regardless of infusion duration. Clevidipine is metabolized by nonspecific plasma and tissue esterases, independent of hepatic or renal function, a vital consideration in multi-organ failure or post-bypass patients. The drug's small volume of distribution and rapid hydrolysis make it one of the most titratable antihypertensives available. Clevidipine is characterized by a potent decrease in systemic vascular resistance and mean arterial pressure, with minimal effects on heart rate, pulmonary vascular resistance, or cardiac index. Because it acts exclusively on the arterial side, it reduces afterload without causing venous pooling. For most patients, heart rate increases only slightly due to baroreceptor activation, but the change is clinically insignificant compared to nitroprusside or nitroglycerin. This hemodynamic signature, strong afterload reduction with stable cardiac output, makes clevidipine a first-line choice for hypertension in patients with systolic dysfunction or impaired diastolic filling. Clevidipine is supplied as a 0.5 mg per milliliter lipid emulsion, similar in composition to propofol. The infusion typically begins at 1 to 2 mg per hour, doubling every 90 seconds until the target blood pressure is achieved. Most patients stabilize between 4 and 16 mg per hour, though the upper limit is 32 mg per hour. Because of its rapid offset, titration can be fine-tuned in real time. If hypotension develops, simply stop the infusion, and blood pressure returns to baseline within 5 to 10 minutes. This pharmacologic agility allows anesthesiologists, intensivists, and nurses to maintain near-perfect blood pressure control throughout cardiac or neurovascular procedures. The most common adverse reactions include headache, reflex tachycardia, and nausea, all related to the sudden drop in afterload. More serious effects include rebound hypertension if the infusion is discontinued abruptly, and rare cases of atrial fibrillation in susceptible cardiac patients. Because clevidipine is formulated in a lipid emulsion containing soybean oil and egg phospholipids, it is contraindicated in patients with hypersensitivity to these components or those with defective lipid metabolism, such as pathologic hyperlipidemia or pancreatitis. Clinically, the most important principle is controlled weaning. Avoid abrupt discontinuation, and always ensure transition to oral antihypertensives before stopping the infusion. In cardiac surgery and heart failure patients, Clevidipine provides a clean afterload reduction without depressing myocardial contractility. In beta-blocked patients, reflex tachycardia is blunted, making its hemodynamic profile even more predictable. In aortic stenosis, caution is advised. Excessive afterload reduction may compromise coronary perfusion. However, in mitral regurgitation, clevidipine improves forward flow by reducing systemic resistance. When combined with antiarrhythmics or inotropes, its effect is synergistic, but should be carefully titrated to avoid hypotension during transitions. Following cardiopulmonary bypass, systemic inflammatory response and hemodilution alter drug distribution and protein binding. Clevidipine rapid metabolism by plasma esterases makes it remarkably stable in this context, avoiding the unpredictable clearance seen with other agents. In the setting of vasoplagic shock, clevidipine should be withheld, as its pure vasodilatory profile can worsen perfusion. However, in low-output syndromes or situations of elevated afterload, clevidipine allows the ventricle to eject more efficiently while maintaining coronary perfusion. Titration should aim to optimize perfusion pressures, targeting MAP 65 to 75 millimeters of mercury and wedge pressures below 18 millimeters of mercury, while monitoring for rapid hemodynamic shifts. In short, clevidipine gives post-op teams surgical-level precision in blood pressure control without lingering effects. Clevidipine is contraindicated in patients with known allergies to soy or egg products, severe aortic stenosis, or defective lipid metabolism. Caution is warranted in patients with acute pancreatitis, as the lipid load can exacerbate inflammation. Because it is formulated as an oil-in-water emulsion, the infusion line should not exceed 12 hours of use per vial to prevent bacterial contamination. Always use a dedicated line and discard any unused portion after that period. Strict aseptic handling and continuous hemodynamic monitoring are non-negotiable when using this agent. 3 pearls to remember with clevidipine. First, it is the fastest titratable antihypertensive available, with a context-insensitive half-life, meaning you can stop it at any time, and blood pressure recovery is immediate. Second, it's a pure arterial vasodilator, ideal for surgical hypertension but ineffective for preload reduction. And third, always consider its lipid emulsion base when managing nutrition or concurrent propofol use to avoid lipid overload. These pearls separate routine management from expert-level critical care pharmacology. Clevidipine exemplifies the next generation of precision pharmacology in the ICU, a drug designed for control, safety, and predictability. From its receptor-level action to its context-insensitive kinetics, it empowers clinicians to manage hypertensive crises with surgical precision and minimal risk. This is Pulse and Pressers, reflecting on the marvels of the human body. Subscribe to stay sharp.